Hello and welcome to the webinar, Supportive Housing for DDHJ Communities, How to Start a FUSE Initiative in Illinois. My name is Mary Ann Dyer, Adult Redeploy Illinois Program Director at the Illinois Criminal Justice Information Authority. This webinar is part of the Illinois Data-Driven Health and Justice Project. Illinois has joined a national initiative to find ways to use data and share information across systems to better identify and address the needs of people with complex behavioral health issues who cycle through emergency departments and jails. These individuals are sometimes referred to as super utilizers. The purpose of these webinars is to provide a foundation of knowledge about super utilizers to facilitate productive conversations about how to intervene earlier for more positive and less costly results. This webinar will describe CSH's National FUSE, which is short for Frequent Users Systems Engagement Model, which applies a housing-first approach to superutilizers and is based on data-driven problem solving, policy and systems reform, and targeted housing and services. The focus of this webinar will be on the key components of the FUSE model and planning steps to create a local program. Our presenters today are Kim Keaton, Senior Program Manager for Strategy and Impact for CSH, who will provide a detailed overview of the FUSE model. She will be joined by Betsy Benito, Director of CSH Illinois Program, with additional local context. Kim?
Thank you, Mary Ann. Can you hear me okay?
Yes.
Great. Thanks so much. So, hello everybody, welcome and thank you for coming to this webinar today. I am happy and excited to talk about the FUSE initiative with you all and with my colleague Betsy Benito to kind of flesh it out with some local context with what's going on in Illinois in terms of frequent user initiatives as well as some opportunities there. And then we'll be sure to leave 15 or 10 minutes at the end for questions. If you have questions as you go along, don't be afraid to type them into the chat box. So going back 1 second, that's me and that's Betsy. Okay, so the objectives of the webinar, first we're going to review the main tenets of supportive housing, a really brief overview, and talk about why it is an intervention that could be beneficial to high utilizers, super utilizers, frequent users. You should note that I pretty much use these terms interchangeably, so they kind of all mean the same group of folks. We'll describe the FUSE model. We will discuss how data-driven targeting of high utilizers can translate into improved outcomes, and we will take away the main steps to planning a FUSE initiative in your community. So first, supportive housing. What is it? So it's very basic. We could do a long, month-long training on this, but supportive housing combines affordable, subsidized housing and support services for people with serious mental illness, substance use disorders, and/or chronic physical health issues. This intervention helps people to live with stability and independence in their communities. While it's generally targeted at homeless individuals, the intervention can be used to assist the high service utilizing population in achieving recovery and stability. Supportive housing services include case management, mental health and substance use treatment services, and/or coordination with healthcare providers, as well as employment, education, transportation, and other services. Many supportive housing providers adopt case management models that are evidence-based, such as ACT and ICM, utilize peer supports, and partner with health providers such as community health centers to help tenants access critical physical and behavioral health care and remain safely housed in the community. In the housing world, we like to say that supportive housing is best for people who, but for the rental subsidy, wouldn't be able to afford housing, and but for the supportive services, would not be able to stay in housing. So why is supportive housing an important tool for DDJ communities to have in their toolbox. This model was listed as a community intervention, evidence-based community intervention for high utilizers in the DDJ toolkit playbook that was worked on by the Obama White House folks and is now available, I believe, at the NACO DDJ website. And it's really best for vulnerable people like the people with behavioral health challenges that tend to cycle, they're cycling in and out of jail and are homeless. It's particularly good intervention because of the evidence base around supportive housing in terms of both allowing for housing stability and then service use reduction. It's evidence-based, so, for example, permanent supportive housing was the key strategy for ending chronic homelessness among, especially in particular among vets. There was a major investment from the HUD and VA into this model, and it's really ideal for the most vulnerable, like the high utilizers of jail and homeless systems. The wraparound support services that this model provides can help keep a person stable and housed, and these wraparound support services are individualized to meet the needs of the consumer. It's not the only strategy to reducing the cycling between jail and health facilities, but it's a diversion strategy that DDJ communities should consider adding to their toolboxes, especially in Illinois. So Fuse, these are a couple of Fuse clients. One, the gentleman on the bottom, is in Mecklenburg County, North Carolina, where Charlotte is, and the one on the right is in Los Angeles. As Marianne said, Fuse stands for Frequent User Systems Engagement. And so the overall concept is that there are thousands of people in communities all over the country with chronic health conditions that cycle in and out of jails, diversion courts, hospital emergency rooms, and homelessness in an uncoordinated way at great public expense and with limited positive human outcomes. Targeted supportive housing for this most vulnerable and costly of this group can reduce costs while getting better outcomes. And finally, by finding a solution to the frequent user issue, the Fuse program can serve as a catalyst for systems change by bringing multiple stakeholders around the table to discuss a common problem, frequent users. So this Fuse has grown into something of a national movement. It's a state signature initiative, and it started in around 2007 in New York City, based on the results, what they thought were surprising results of a data match between the New York City Department of Homeless Services and the New York City Department of Corrections, the jail. They found a huge overlap and decided to come up with an intervention to really help the most vulnerable. As the movement has grown, we've seen most communities do this focus really on the same homelessness and jail population. A lot of communities too have, in order to reduce emergency crisis health costs, have focused on frequent users of, for example, emergency rooms. And then now, much like the DDJ efforts, we're really seeing and focus on those folks in the jail who are also costing a lot in our local health system. So we've learned that's a lot of communities, a lot of dots on that map. Along the way, we've learned some lessons about how to do this right. First of all, data-driven problem solving from soup to nuts is really important. And so by that I mean starting with data matching to identify the most frequent users of more than one system's costly services. This is really important to get buy-in from multiple systems in order to agree on a common definition of a frequent user, and also to make sure you're targeting the most vulnerable. To utilize a list-based outreach to the streets or inreach into institutions approach ensures that you're not just waiting for folks to come to you, you're actually going to the most vulnerable and costly. Using data to measure and track program implementation and outcomes, looking at things along the way, such as how long it's taking to get folks into housing, who's staying in housing, what are their issues, and system, what is system use before and after housing are important. And these all feed into evaluations of programs. So Local evaluations of fuse initiatives really help to demonstrate the results to local stakeholders or people, you know, who hold the purse strings in your community, and to help scale the model. So overall, using data from multiple systems for targeting, outcome tracking, and evaluation helps communities arrive at a new and shared definition of responsibility and success. So systems working together can reform. This is part of that policy and systems reform piece. Really, public systems in communities and policymakers really engage in a collective effort to address the needs of shared clients and to hopefully eventually shift resources away from costly crisis services and towards a more cost-effective and humane solution, which is permanent supportive housing. In terms of how this looks on the ground, ongoing meetings of stakeholders, not just once or twice, but as the program's being ramping up to implementation, and then through implementation, helps ensure barrier busting for tenants with multiple issues. These are folks that have, you know, they may have child support arrears, they have warrants out, they have bad credit, they have all sorts of things that can keep them from being successful. So having multiple stakeholders around the table in an ongoing way really helps ensure success for these people. We've learned that one-time data matches don't really live beyond a pilot project, so more work needs to be done in communities to really integrate data-driven targeting more deeply into how, you know, the way of doing business. And then engaging with what's called coordinated entry or coordinated access. It's a homeless system term that I'll go through in a little bit. Really early on in the project is key to ensuring prioritization of those housing resources. And really what needs to happen is the systems working together need to develop partnerships, and that can emerge as the most effective means of serving frequent users who are bouncing around all the different systems. The targeted housing and services work. This is, of course, the most important part of the FUSE model. As Marianne mentioned, it implements a housing-first approach. So for those who are not familiar with Housing First, it's a homeless assistance approach that prioritizes providing people experiencing homelessness with permanent housing as quickly as possible, and then providing voluntary supportive services as needed. So on the ground, what that looks like is perhaps not requiring somebody to be sober and engage with mental health services before giving them a key to their apartment. The Housing First approach really believes that it's the housing that's the biggest problem, and once that's stable, that, you know, part of a person's life is stabilized, then they can move on to the other aspects that they need to work on, or that they want to work on. So, you know, stakeholders, in terms of coordinating housing and services, stakeholders need to coordinate on outreach and referral to find and engage tenants. So this is really not a service-seeking population. Folks need to work together to really find the most vulnerable folks in their community, and that the services need to be appropriate for for this enhanced approach. So moving on, you're probably wondering what the outcomes are. Well, there are, you know, overall providing frequent users, super utilizers, high utilizers, assistance with safe, stable, and quality supportive housing can lead to increased cost savings or cost offsets from systems, increased system collaboration, better quality of life, not only for consumers, but potentially for public safety and communities, and then better self-sufficiency for the tenant. On the decrease side, we see huge decreases in shelter usage, substantial decreases in jail use and arrest, and then also decreases in emergency rooms, particularly emergency transport systems as well. You can find more information at the link below. There's actually, we have a whole section of our website dedicated to FUSE. We'll be sharing that website with you at the end of the presentation, but if you want to go ahead and get on it right now, it's csh.org/views. So I said earlier that the program began in New York City. So Columbia University evaluated that initiative, and these are the results from that evaluation. They did a matched comparison group and followed them over 2 years. And so what they found was, compared to the comparison group, these participants had 40% fewer jail days. So they were not only going back to jail less frequently than the comparison group, but they were staying for shorter amounts of time. There were 91% fewer shelter days, so they basically just stopped going to shelter altogether. And they had 50% fewer psychiatric inpatient hospitalizations, which was a self-report measure. The evaluators did a cost-benefit analysis and showed that just based on these results, and keep in mind we didn't have any data on health system usage, the cost-benefit analysis showed that there was a $15,000 savings per year per client, and that's after accounting for the cost of housing, the rental, and support services. Now, what's not shown on this slide is what I think is perhaps the most important result from this evaluation, was that at 12 months, 90% of fused participants remained in their fused housing, and at 24 months, 86% remained in housing. Most did fused housing, some had moved on to independent living. So housing stability was achieved. So you saw a lot of dots on that map earlier. There have been, a lot of really great results to come out of these efforts. You see 4 examples here. Maricopa County, Arizona, where Phoenix is, did a small pilot focusing on folks with high hospital usage, and they found a huge reduction in inpatient days, ER visits, and a 100% reduction in jail days. In Hennepin County, Minnesota, where Minneapolis is, there were fewer arrests, there were massively fewer shelter nights, and a lot fewer, quite substantially fewer nights in jail. Connecticut has a statewide program that's been expanded a couple times, and they consistently have found a reduction in jail days after a year. Finally, most recently, the Justin Reach program in Los Angeles, was demonstrating really great early results, showing a 20% reduction in jail days after about a year in the program, and they were awarded HUD DOJ funds to expand the program, scale it up using a pay-for-success funding model. So that tells the tale in some other communities that we've worked in. I'm going to turn it over to Betsy Benito right now, and she's going to talk about some of the efforts and opportunities in Illinois.
Thanks, Kim. Good afternoon, everyone. There have been initiatives of the FUSE model that began about 10 years ago, and it was initiated in the city of Chicago, which isn't listed here. So we do have some experience, and I know we have a lot of great communities on the call that have been participating in this effort over the past year. Just wanted to highlight some current activity that we're working on from the CSH end is in Rockford. Their mayor is and their housing authority are quite invested in health centers and how health centers are serving public housing residents, and have been very active in their effort around ending homelessness and ending veteran homelessness. So they are pretty experienced at this point in how they're collaborating across city agencies. And so the discussion around creating a FUSE initiative is in the beginning stages, and CSH is working and providing technical assistance in that community through our federal HRSA, through the Department of Health and Human Services. We have some assistance to work with communities that are coming at housing and health initiatives. In Aurora, it was our Illinois office that partnered with the city of Aurora and 2 hospitals, Presence Mercy and Rush Copley, who were responding actually to an effort that was led by the police and fire departments, initiated actually through the outgoing fire chief, where the police and fire were recognizing that they were spending a disproportionate amount of time transporting people experiencing homelessness who were intoxicated, that were receiving calls from the community either through concern or through complaint, and transporting them to a hospital emergency room where they may stay for a behavioral health episode, or they may need to retain or regain sobriety, and then the cycle would begin itself again when the hospital would discharge the individual back to the street or to the train station, and then they would make their way to the homeless shelter again. So this was less data-driven, where data systems were talking to each other, but what's been happening over the past year is that they were able to develop a memorandum of understanding across the different community-based providers, the city agencies, and the hospital systems to then commonly identify and assess individuals that would allow the partners to talk to each other about how to intervene with the particular individuals. So out of the top 19 people that all the partners had identified, 9 have been housed, 2 passed away, and they have developed a couple of new community interventions to help decrease the amount of time that the emergency services are spending on people who ultimately need housing. So that's an initiative where our CSH Illinois office, my team, provided the support for the pre-operational planning and got the community to their implementation point. Next slide. In addition to highlighting those communities, I was asked just to provide some additional context of some current discussions at the state level that may help communities create or successfully carry out a FUSE initiative. And as has been highlighted, the people that we're talking about are those that have higher behavioral health and maybe higher substance use needs in addition to a housing need. And this sort of person-centered approach of giving folks what they ultimately need around housing and services, the state is recognizing that it needs to make changes to the behavioral health system so that it is more appropriately delivering services and then ideally controlling cost and over time reducing cost. So the state of Illinois has submitted what's called an 1115 waiver, and Medicaid waivers allow the state to limit services to subsets of populations as opposed to making benefits available, these specific benefits available to all populations. It helps to kind of carve out new benefits or a combination of benefits that are eligible through Medicaid, but to test them and their cost neutrality with specific subpopulations. So this waiver was submitted at the end of 2016, and there was concern after the election with the new administration that the waiver would not move forward. All signs are that the waiver is still in negotiation between the federal government and the state, and that there still is a expectation that it will be approved and could begin implementation then early next year. The overarching goals are to rebalance behavioral health, so it's really looking at substance use and mental health, pulling in healthcare and having these integrated care models, differentiating how services are delivered between high need and low need, and then it recognizes investments in supportive services such as housing and employment. So employment being supported employment, which really is a model for people with disabilities, kind of an employment-first approach. And then really looking at outcomes and how services deliver value add instead of paying for just a fee for service and a volume of service. And a lot of these goals align with what's just been described of why to look at within your systems of care people who are kind of using the wrong type of services and getting poor outcomes, how you can work together to change that picture and change those ultimate outcomes. Go to the next slide. Some specific components and activities that are outlined in this pending waiver include supportive housing services, so these pre-tenancy supports and tenancy services, so housing assessment, housing search and placement, overcoming barriers to housing, and then helping someone maintain their tenancy, maintain their lease compliance, and how to be a good neighbor, pay rent, crisis services, eviction prevention. So that's all right now reflected in this waiver. I mentioned supported employment. It talks about reentry services and how to improve the connection to people exiting jail and prison into healthcare and other behavioral health services so that there's a seamless transition. Substance use services that have to do, I think, with the opioid addiction. I mentioned integrated health homes and some of these other prevention services and getting some changes to the way that we deliver mental health services in Illinois. So those are, from the service end, some really key potential changes that could help the providers in your community or the systems that deliver some of these services in your community that you'll want to pay attention to. And this is in the backdrop that the state is expanding managed care statewide, is doing an RFP to select managed care companies and to actually reduce the number of managed care entities throughout the state. And then I think something that I failed to put onto a slide that I'll put in the chat box that everyone can receive the link is that at the same time from the housing end is that the state of Illinois is, and its collaborators, so state agencies and community partners have come together to create a what's called a supportive housing working group report, and the state has been trying to determine the scale of supportive housing resources that are needed across a variety of populations. And one of the areas is around reentry, both at the prison level and the jail, the county level. And some of the struggles is to help really understand what is the need, and then what would be the ways that the state could really support the creation of housing for these populations, and what other policy components. So I'll put the link to this report into the chat box, and so that you can all receive it. So those are just some of the things that are happening in Illinois that may relate and help with thinking about a FUSE initiative. And in addition to following up with Kim and myself for specific questions, if you have a need or want to talk with us programmatically of how we can support you, please feel free to reach out.
Thanks, Betsy. So now that you have in the back of your mind some cool opportunities that might be happening in Illinois, we're going to go through the 5 steps towards creating FUSE in your community, and I'm happy to report that you guys have pretty much already done probably 1 and 2. So engaging a local champion in order to become a DDJ community, you pretty much have to get some executive buy-in, and so getting some further buy-in towards using FUSE or supportive housing as one of your diversion tools would be the logical next step there. Identification of stakeholders. So you're probably talking to a lot of different stakeholders as a result of your participation in DDJ, DDHJ. Inviting them to participate in a multi-sector planning group on a FUSE initiative would be your next step. The third one is scanning and creating for opportunities for supportive housing in your community. We'll go through a couple other things in addition to what Betsy said. Conducting a cross-systems data match. By the way, none of these things, this isn't necessarily sequential in time. You could have already done a cross-systems data match, or you could do that first in order to get the support you need from the executive plan and really uncover that uncoordinated public system utilization patterns that are unique to your community. And then finally, engaging the homeless system leadership in your project. So just a couple notes on a local champion around particularly a FUSE initiative. needs to be really somebody who can bring folks to come to the table to talk about something that maybe hasn't been done before. Someone that when an invite comes from their office, people show up. It could be an organization or a person, so a sheriff or a judge, you know, a hospital, a health center, an MCO. I frequently see it being not necessarily elected officials, but high-level county executives, like commissioner level, or just one example in Los Angeles is the housing department of the the public health system. And then finally, a homeless system lead or a continuum of care lead can also lead the charge for a few initiatives that happen, for example, in Richmond, Virginia. So, you know, the champion isn't necessarily the project manager. The project really does need a good person to push it through, to get those meetings set up. I know it's kind of a slog, but that's some of the real bread and butter of an initiative like this that really relies on multiple people coming to the table. And so, how do you get those stakeholders? I'm sure you folks have thought about this already, but you know, first of all, what systems do frequent users touch? It's not just jails, courts, street, you know, beat cops and the like there, but there's also emergency transport systems which often are run by fire departments, see a tremendous amount of turnover of the same folks calling 911 or getting 911 called for them while they're outside. Obviously, hospital, folks are using shelter, transitional housing. They may be doing some inpatient, short-term inpatient stays at psychiatric hospitals, which are incredibly expensive. And then finally, engaging with the substance use system. Thinking about all of these systems, they're not all going to be resource-rich in terms of providing resources like funding for your initiative, but they might be influential in the community politically. They may have data good data, and be good at sharing data. They may, you know, be a place where individuals in the community really, you know, like a drop-in center or something where homeless individuals go there a lot, so it would be a good outreach place. There's all sorts of roles, not necessarily money roles, but roles for different stakeholders in an initiative like this. So step 3, scanning, creating opportunities for supportive housing. Of course, you know, CSH offers month-long, you know, institutes on creating supportive housing, so I am not doing anything justice by just providing a list here. Betsy talked about some of the new opportunities coming through the 1115 waiver and the state, and then the first place you want to start, if you haven't already, is talk to your continuum of care leadership. That's the body of providers that is funded by HUD to provide a homeless services continuum in a geographic region. The leadership of that, you know, we commonly refer to them as COCs. They will really be the first system to talk to. There's also, you know, state and local support housing initiatives, not necessarily Illinois right now, but one thing you may have heard of through your work with DDHJ, I think they've had a couple of webinars on pay for success and social innovation financing. So these initiatives have provided other sources of funding to scale up evidence-based models like supportive housing. You know, other opportunities, and I'll just point out federal grant opportunities. I was just speaking to, not Illinois, but somebody in Missouri yesterday was applying for a SAMHSA grant to provide supportive services in housing for frequent users. And so BJ stands for, you know, I think you know that, Bureau of Justice Assistance. So the Second Chance Act often has permanent supportive housing listed as an evidence-based model that's eligible for funding. And then finally, there's the Medicaid waiver piece. A lot to talk about there. For doing a real proper scan in your community is something potentially CSH could help with. So step 4, cross-systems data matching. Of course, the whole point of the DDJ effort has been to really, talk about the frequent users of health services and criminal justice correction services. And so, we've, as CSH has been involved in that initiative, we've been singing the verses of homeless system data and how useful it can be for health and criminal justice systems in order to really determine those high utilizers that are most in need. This is basically talking about taking criminal justice and homeless system data and putting it together to see what the overlap is. We're going to go through that a little bit more detail in a minute, but in general, most communities are really focused at the county level because that's how jail data is organized, and often homeless data is organized that way too. More recently, we've been seeing, and neither of those are HIPAA protected. More recently, we've been seeing jail and homeless data flowing upstream to sources that can match in a HIPAA protected environment, like hospitals, and even managed care organizations that are covered under HIPAA, since that data can't really flow back into a non-HIPAA protected environment. Statewide data, some states keep their data at the state level. So, for example, in Connecticut, we've seen the statewide homeless data matched with both Medicaid and the jail system, which is also statewide, to identify the top users. And then there's examples where only de-identified data was available. And so some researchers in Los Angeles took matched county records and used them, crunched the numbers to find conditions in system usage patterns that predicted the likelihood of a person being a top utilizer, and created a tool that's actually available online. Follow up with me if you'd like to link to it, called the triage tool, put out by the Economic Roundtable in Los Angeles. And step 5 is engage your coordinated assessment system. So what is coordinated assessment? What am I talking about here? Well, homeless, like I said, homeless systems are organized into a continuum of care. HUD has mandated that COCs basically come up with a way to make the system work a little bit better for consumers and control and prioritize access to housing resources for those that are the most vulnerable. And it's a lot more complicated than this, but why I think that justice and health systems should care is that it really helps reduce that black box effect of the homeless system. So, you can, often, people will be discharged from either a jail or a hospital, and they're just, you say, oh, go to the shelter, but you don't know what the shelter is going to do for them. Coordinated entry provides an intake point where their vulnerability and needs will be assessed, and then they'll be, prioritized for access to housing if that's what they need. And of course, depends on the resources available in the community, but it certainly makes for referral, less effort on referral, and engagement from justice and health systems at the high, in the sort of planning framework for coordinated assessment could really help those systems have a say in how consumers are targeted and provide, hopefully better access to housing for folks to keep them from coming back. That's sort of beyond the Fuse initiative. It's just something to really think about in your community. So real quick, I'm going to go through gathering the data to serve the most vulnerable, highest cost. And if this is a remedial lesson for some of you, I apologize. Hopefully it's useful for some and remedial for others, but I feel like it's useful sometimes to take a step back and really identify what we're trying to talk about without getting too technical. So data matching has lots of purposes. It's not just to look at a list of people and see what the overlap is. It can be used, like I said, over and over to target and refer users of multiple systems for support housing, of course, but for other interventions, diversion efforts as well. It can be used to perform cost-benefit analysis of system attach costs to each booking, to each jail night, to each shelter night, etc., and really come up with what are frequent users costing a community. And that really can help generate support for your initiative. And then it helps, you know, when a program such as Fuse is being implemented, having data matching can really help systems collaborate and coordinate services better for better outcomes. So as you look around in your communities, there are a lot of players in local systems of care, and each can potentially be a partner in a supportive housing and healthcare initiative. You know, frequent users really touch all of these systems. You don't need all of this data, but this is all sorts of systems that you might want to think about. So at very, you know, simplest level, finding the target population is basically like a Venn diagram. It's finding that overlap in the middle of the circle, so between ER, jail, prison, detox, you know, hospital, inpatient records, and, you know, looking at the people who are, you know, in the highest decile, for example, of that group, and how that overlaps with data from a local homeless management information system. You know, in the very center there, you're going to see the overlap of folks that are not only using systems most, but are highly likely to have behavioral health challenges as well as physical health challenges that are really keeping them from you know, keeping them coming back and using the services over and over. That on the hospital side and the homeless side. So, okay, data sharing flow. Quick, just, you know, data often when you're sharing corrections data with homeless system data, it's generally homeless system data is somewhat more protected than corrections data, and it would flow. Files would flow that way. Homeless system data is not subject to HIPAA. Of course, health, hospital, and MCO data is mental health and substance use data has some special regulations. So this is just to show you that when sharing data, it should go from the least restrictive to the most restrictive environment. If you haven't done this yet, some questions to ask in your community. You know, first, investigating where, you know, data is in terms of quality. Some homeless systems have great data, some not, some don't. So potentially, if there, you know, if the homeless system data isn't that great, is there, you know, potentially like a service site that's, you know, in use by a lot of the homeless population? Maybe that's a better fit. Looking for an existing frequent user analysis. So many shelters or homeless systems, ERs, jails keep their own frequent flyer super user lists, you know, the folks that they keep seeing coming back. I've seen communities, particularly one called Project 25 in San Diego, that just took all these, you know, frequent user lists from all these different systems and put them together. And when they did that, they found people who were on everybody's list, and that really generated a lot of support for the initiative. You also want to ask where is the analytical capacity in your community, as well as where there are already existing data sharing agreements that can be amended or built on for a new match. So just one last note on coordinated entry, and then I'm going to talk about something slightly different. So guidance from HUD has stated that matched administrative data really can be used to form a housing waitlist as long as chronic and other vulnerability requirements are met. Some communities have worked it out by assigning extra points in the assessment process to people with matched records who are on the housing waitlist, or creating a scoring rubric based on several conditions being met. Also, some communities just add specific questions about service utilization. Those are different ways that you can integrate Fuse into a coordinated entry system, which is probably what should be done. So I've talked about data matching, I've talked about supportive housing, and I've talked about a little bit about Waiver success. I wanted to use this opportunity to tell call folks about, you know, a new thing that CFH is offering, an RFP actually, that will really help move from data matching to integration to scale up supportive housing initiative. We have an RFP out on the streets right now called Scaling Data Integration, Advancing Pay for Success, System Change, and Supportive Housing for Vulnerable Populations. I'm going to skip ahead for a second here. You know, really what we're talking about, the opportunity here, we're going to be selecting 4 communities and governments are eligible to apply. We've hired the University of Chicago as a developer to create an integrated web-based tool to, you know, consistently and over time match jail and homeless data. So it's not just a one-off effort. So the idea is that the communities that are selected can really truly integrate these systems data to capture and measure the true system uses and costs of frequent users. And we know from all the evidence that we've talked about that targeted supportive housing for this group will reduce system uses and costs. And so this opportunity will allow recipients to not only integrate data and learn more about CFH's fuse model, but will also prepare them to conduct, you know, basically feasibility assessments for implementing pay for success models that support scaled up supportive housing interventions. And, you know, one of the issues with pay for success models is that there's often not the data to really measure what those system reductions are. And so, you know, this opportunity will allow communities to really build that infrastructure. Like I said, eligible applicants are government, state, city, or county, or tribes participating in data-driven justice. And the applications are due April 7th. The population of interest is exactly who you're trying to look at, individuals who are part of that cohort of people cycling between jail, shelter, and other public systems at enormous expense with poor outcomes. These are some of our partners. I just want to note that we're being funded by the Laura and John Arnold Foundation and the Federal Social Innovation Fund to do this work. We're going to select 4 communities. You'll receive access to this tool that will integrate your criminal justice and homeless data. Technical assistance will be used to accelerate the development of pay for success projects. You know, just one note is that the assistance does not directly fund housing or services. It is time for the Q&A. We have about 12 minutes. Instead of putting this fun picture of people talking, I'm actually going to go to the resources page here at the end, so folks can, you know, look at some of these links, maybe check them out and see if you have any questions.
Thank you, Kim and Betsy. Lot to think about. And one thing is that you've definitely put forward a very comprehensive model with just a 360 view of the individual. I wanted to encourage people first to provide us with questions in the chat box on the right-hand side of your page so that we can be having, you know, direct these to the experts that we have on hand today. But we can also encourage you to look at, to use the contact information that we've provided here at the end of this webinar for both Kim and Betsy if you want to follow up on an individual basis. But in addition to using the expertise that we have on hand now, I want to encourage everybody to go to this FUSE Resource Center at csh.org/FUSE. It is an amazing wealth of information, a one-stop shop for any community that is even considering this. Initiative for their community, and it includes a FUSE 101 section. It includes case studies, which have been shared today, research that supports this approach and the Housing First approach, and even templates of different documentation that you may need to keep this get this initiative off the ground and keep it going forward. So highly recommend folks go to csh.org/fuse, and there's a link to this on the DDHJ web page. So let's look and see. We do have one question here. What thresholds have you utilized to identify frequent utilizers of the emergency department or the criminal justice systems? And I would place that to Kim, I think in particular. Do you see any kind of consolidation around particular numbers?
Yeah, that's a great question, Sal. Communities tend to kind of do it on their own, and sometimes it's really unique to a community. But some trends that I see are the top 10%. When you top 10%, top 5%, and so there's a lot of studies done that talk about something called the 550 rule. 5% of people taking up 50% of the resources. So whether that's funds, whether that's Medicaid costs or bed nights out of jail or something like that, there's a small and there's a small group of folks that are taking up a disproportionate amount of the resources. So that's been the 10%, like top decile. When you look at that, the difference between that and like the next threshold, it's a big difference, and then things kind of even out and go down from there. So that's something that people have used, particularly on the ED side. In criminal justice systems, it's often utilized instead of the percentage, it's usually stay criteria or booking criteria. So folks have used 3 bookings in the past year, paired with 3 shelter stays in the past year, or I've seen that go back as far as 4 years, to really identify people who have demonstrated a history of cycling between systems. Oh, I'm sorry, that question was from Bill Watson. It all looks to me like they're from South Carolina. I apologize, Bill.
One other question that I had related to the conversations is data matching obviously is key, and we had a webinar with the Center for Data Science and Public Policy from the University of Chicago a few months ago. But how long does this process generally take? And I mean, obviously you could go through this whole process with a pay for success RFP and work with a technology company to come up with that. But if you're just trying to do this with, say, rubber bands and paper clips, how long does the process take? And then also, how frequently would you have to kind of refresh the data matching to, properly inform your program?
That's a really good question, too. If you have, at the time in which you're beginning to plan a FUSE initiative, if you have the housing and services funding in place, then from data match to housing can take as little as 6 months. I've seen that. If you don't have the resources in place for housing and services, then you're going to have to go out and look for them and use a data match to generate sort of energy around that. So then I would say you would plan on about a year and a quarter. If your housing, depending on the size of the community, if you have a list and you are housing folks, it's really the refresh needs to be done probably at least every 6 months.
Okay.
This is Betsy. I would just add that some of the conversations that I've been in have been using the data match to confirm kind of what the question from Bill was around kind of setting the parameters of what's frequent use and what's sort of that kind of profile that you're looking to target, and then having a way to assess people and then finding your target group from the assessment as opposed to data matching and then continuing to look for specific people, of knowing the type of person that you're looking for so that you can kind of capture them. Not capture, that's a bad word, but that you can identify them and engage them in services as you encounter them next.
So Betsy, this question will go to you. What is the greatest barrier to implementing FUSE initiatives across Illinois? I know we have a very strong CSH Illinois office here, and I think it's probably a little unfortunate that we do not have a model FUSE program in Illinois yet. So are there any like structural barriers or policy barriers in Illinois that our DDJ county should be aware of?
I think the barriers are a little bit less structural, and from my experience, it's really kind of who is the champion, and that it does take stamina to initiate a FUSE project or any initiative that's targeting high-need populations, and and sticking with it and thinking through all of the parts. I think for systems of care like reentry or health, housing, it's just housing is a really big category, just like I said, reentry or health. There's many different parts of those those networks of providers, and that it takes some time to make sure you're really thinking through the housing options and bringing people to the table. So I think often times that sort of political will and that the leadership and the different partners are kind of owning, really feel a sense of ownership around who you're trying to serve and the outcome that you're trying to achieve, and that it's going to lead to some sort of bigger change. So, there's always a shortage of housing, but if you as a collective are like thinking strategically or integrating in with other trends that are happening, like this whole idea around targeting people experiencing chronic homelessness, that's a great win of how to work with a homeless system of care, or just paying attention to like different housing resources that are out there. You really can kind of pull things together, but it is a longer effort. It's not a quick fix, and so who you have at the table should really feel a sense of kind of ownership and investment in it.
That's a great question, and the longevity or the stamina point leads one to believe that it's good to have probably elected officials at the table, but also people who are going to be around the table in a capacity that extends beyond, say, election cycles.
Exactly.
And that have specific incentives. And before we move off of this, I just wanted to ask you quickly, Betsy, about the 2 hospitals in the Aurora conversation. Are you familiar with the incentives that will have brought them to the table?
They, those 2 hospitals just were seeing, they were spending and seeing a lot of the same population. So President's Mercy is the hospital that gets the most traffic, and but as a mission-driven hospital, they also want to deliver better services and partner with the community. So for them, I think it was more in line with, how are they really, what is their goal with delivering services and trying to change that and partner with the city and providers, where they also were already funding community-based services, like for substance use and such.
Thank you. We have another question that we're right at the 3 o'clock, but if we could put this question up to Kim in particular. First of all, is whether the PowerPoint slides will be available on the website, and I can tell you that yes, they will, in the next few days. But is there a quick reference guide as to what type of information can be shared across systems? So, for example, probation records are confidential unless released by court order. And I'm thinking back to that wonderful graphic of the intersecting circles.
Yeah.
There we go.
Yeah.
Okay. Is there any further, I guess, definition around, say, this slide 31?
There is in parts. I can't think of like a one-stop shop. There's on the health side, there's like a homeless and health data paper that the National Alliance on Homelessness put out last year that we helped put together. There is, on the correction side, it's, you know, I am unfortunately not that familiar with probation records. On the jail side, I mean, what's useful is the, you know, obviously identifying information, but also, you know, booking and any sort of, you know, booking date, release date, any charges. So sometimes communities really want to look more at that. You know, there's, I can't think of a quick reference guide right now, but I can think of one and get back to you, hopefully.
And Steve, I know that you know this like the back of your hand, but I know we're looking at the first webinar we did for the DDHJ was on the sequential intercept model and the focus on intercepts 1 and 0. So prior to probation, hopefully finding and identifying these individuals and deflecting them earlier on in the system than probation. So that doesn't really answer your question, but I hope it addresses it. So we've come to the end of the hour. I want to thank everybody for your attention and interest in this topic. Thank you for participating in this webinar, and thank you to our presenters. Just want to remind you that you can visit the DDHJ website here at www.icja.state.il.us/DDHJ. We'll be posting this webinar on the website, and we also encourage you to access a wealth of resources from our December 2016 conference. Includes all the PowerPoints from that conference, as well as links to resources including the Fuse Resource Center and the NACO site that was mentioned earlier, which is now the repository for the DDJ work that came out of the White House initiative from the last 2 years. Thank you, everybody, and please keep checking in on the DDHJ website for additional webinars and sign up for the listserv. Thank you.
Thank you, everybody.